After medical management, now we'll be shifting to the key points in surgical management of glaucoma. So when do you do surgical management? When there is glaucoma progression on medical and laser therapy, that is maximal tolerated medical therapy, that is more than 3 class of medical drugs are not enough to control the intraocular pressure. Also in advanced glaucoma with high IOP on presentation, low target IOP is desired, that is family history of glaucoma or normal tension glaucoma. When there is poor compliance, adherence, or if there are socio-economic problems. So we have surgeries to improve outflow, that is penetrating glaucoma surgery. Then we have non-penetrating glaucoma surgeries. We have minimally invasive glaucoma surgery, angle surgeries. We have glaucoma drainage devices, and then we have surgeries to reduce inflow. So we have lot of surgeries in the glaucoma to reduce intraocular pressure. So how to make a decision? It depends on the safety and efficacy of the procedure. Also, it depends upon the glaucoma disease spectrum. As Madam told you that we have now 3 groups, that is mild, moderate and severe glaucoma. If it is a mild glaucoma, the target is between 15 to 17 mm of Hg, and we can have medical therapy, we can have laser trabeculoplasty, or we can have cataract extraction, especially in cases of narrow angle glaucoma. If the disease is moderate, then the target is between 12 to 15 mm Hg, and we can have mixed procedures for these type of glaucomas, that is mild to moderate glaucoma, along with cataract extraction. If the disease is moderate to severe, then we can have trabeculectomy with mitomycin C. We can have trabeculectomy with cataract extraction. And if the disease is severe, then we can have tube shunt surgery or endocyclophotocoagulation. So depending upon which severity of glaucoma, we can choose a procedure. What are the pre-operative assessment? So we now are shifting our focus to the gold standard, that is trabeculectomy. So pre-operative assessment include good history and examination, which is very crucial for any glaucoma procedure. Identify high risk cases for bleb failure, that is young age, myopia, previous trabeculectomies which were done, ocular surface disease, and also if there are blepharitis, you have to treat them before taking patient for glaucoma surgery. Identify areas of immobile conjunctiva with Q-tip, and that is how you can plan the filter position. Look for active inflammation in anterior chamber, that is AC cells, and you have to treat uveitis before taking patient for trabeculectomy. Vitreous in AC, also lens status. Do fundus evaluation and gonioscopy of both eyes, which is very important. Don't just treat one eye. Do gonioscopy of both eyes. Pre-operative preparation include written consent, and for glaucoma it is very important to tell patient that this surgery is not for improving vision like cataract extraction. This is to maintain vision, and here vision may drop by 1 line after surgery. Also tell patient may need anti-glaucoma medication in post-operative period. There may be need for repeat surgery. Continue systemic medication, as most of the patients have systemic problems like diabetes, hypertension. You can stop oral anticoagulants after consulting physician. Start topical antibiotics and steroids. Give pre-operative IV mannitol to avoid suprachoroidal hemorrhage on table, especially in cases of narrow angle glaucoma. Avoid excessive ocular compression while giving the massage after anesthesia, because the optic nerves are very fragile in these patients. Anesthesia can be peribulbar block, topical, subtenance, intracameral, and GA, especially in congenital glaucoma. So we have Moorfield Safe Surgery System trabeculectomy, which is an evidence-based step-by-step approach to trabeculectomy, which is given by Sir Peng Khaw, and it tells us how to do trabeculectomy to avoid post-operative complication. and it tells us for diffuse and posterior wide application of mitomycin C to avoid ring of steel. You can see the ring of steel which was there before this technique came into picture. Then the sides of scleral flap are kept intact to maximize the posterior flow of aqueous. The conjunctival closure by this technique is by Weiss technique. So the surgical success rate of trabeculectomy is very good. That is more than 75% in cases of primary open angle glaucoma, angle closure glaucoma, exfoliative glaucoma, pigmentary glaucoma, and also angle recession. But it is not so good in neovascular uveitic congenital and when there are two failed filter surgeries. So today I'm going to speak about how to combine mitomycin C augmented trabeculectomy along with small incision cataract surgery. As you all are doing small incision cataract surgery, it is very easy to combine trabeculectomy along with SICS, and everybody can do this combined procedure very easily. So under peribulbar block, superior rectus traction suture is taken, a phonics-based conjunctival flap is created, and this is a small incision cataract scleral tunnel, and then 3 mitomycin C soaked sponges are applied below the conjunctiva, keeping the edge of the conjunctiva away from the mitomycin C. After 2 to 3 minutes, the sponges are removed from the subconjunctival area and the area is washed with 20 cc of BSS or ringer lactate. So thoroughly wash the area of mitomycin. From the side port, the air bubble is injected, and this is again a routine SICS which you are all doing. Inject viscoelastic, perform the rhexis as you are doing for SICS. Then enlarge the lip of the main incision with keratome. Remove the nucleus with sandwich technique or whatever you are comfortable with, and do cortex wash. After that, insert a single piece 5.5 mm PMMA PCIOL in the bag as you are doing. So this is just manual small incision cataract surgery with PCIOL as you all are well versed with. After that, you have to do trabeculectomy. It is as advisable to take pre-placed suture, take Kelly sponge and make internal ostium. It could be 0.5 mm. Then do iridectomy through by Vanna's Caesar and wash it. After that, you have to suture the scleral flap, which can be done by 10-0 nylon using 4 suture loops. And you can take 2 or more sutures like this to cover the scleral flap. And you can also have 1 or more interrupted suture on this. Put the trypan blue dye to see for minimal spontaneous filtration. So here that is what is done. And in the end, conjunctiva and tenons is closed by 8-0 Vicryl in a watertight manner, taking some bites at the limbus to anchor the conjunctiva on the limbus. That way you can achieve a very watertight closure of the conjunctiva at the limbus. So this is all about the conjunctival closure, which we call as the conjunctiva is princess for the trabeculectomy surgery. We have to and in the end, BSS is injected in the AC to form the diffuse conjunctival bleb. So this is a very simple procedure to combine the trabeculectomy with the SICS. Postoperative care is with steroids, antibiotics, cycloplegics, and anti-glaucoma drugs if needed. So considering infrastructure, resources, doubtful follow-up visits, non-compliant patient, and advanced glaucoma which is detected along with cataract, I think trabeculectomy with SICS is a simple and economical solution which has minimal post-operative complication. You can also do phacotrabeculectomy, which can be one side, two side, whatever is, both the techniques are fine. But you can also do this technique very easily, combining the trabeculectomy with mitomycin C along with SICS. Thank you.
Thank you, Dr. Rekha, for such a nice presentation and nice videos you have got.